So right now, I'm excited to turn this over to Hillary Carraz, and she is going to facilitate our first session on translating and communicating PEPFR science. So Hillary, you're on.
Well, thank you very much, Sandra, and welcome to this session on translating and communicating PEPFR science information. I'm Hillary Carraz, Deputy Communications Director at Public Health, Seattle and King County, the local health jurisdiction over in Seattle, Washington. So this session this morning will explore approaches that have been successful or perhaps less successful in taking the science of public health emergencies and communication and packaging them into messaging for diverse audiences, not just the public, but for others who work in the field of emergency response. We have a really interesting panel this morning representing a super wide range of experiences. And I'm going to invite each of our speakers this morning to share their remarks for about 5 minutes, and then we'll have a question and answer period. If you'd like to read more information about the panelists, a link to their bios has been posted on the event page. And again, if you have a question to ask the panel, please put it in the Q&A window in the Slido beneath the video player. So to kick us off, I'd like to turn this over to Meredith Lee-Volmer. She's the Risk Communication Manager at Public Health Seattle and King County. Welcome, Meredith, and the floor is yours.
Thank you so much. So as somebody who works in public health communications, I've been steeped in COVID for the past 2 years. We had the first case in our area in January of 2020. And I wanted to share some thoughts that I've been having about the nature of this event and what it's been making me think about because it's been going on for so long. But also I think that it has application when we think about other public health emergencies and how we communicate. And so, if we go back to that, January, February, March of 2020, I think it was crazy, but in terms of just trying to keep up with everything, but that I feel like the public was much more engaged with the science behind what was going on. And there's a lot of fear going on and people wanting to understand what was happening. But, to me, like the fact that they were using PPE and social distancing so quickly in their lexicon that they were understanding that was really quite remarkable. And the challenges there were that we didn't know all the science and that it was problematic that we weren't getting that information to everyone in an equitable way. But I think that the engagement was much more there. And now, as we all know, the politics, the pandemic fatigue, the messaging fatigue, the amount of misinformation has really changed how the public is reacting to all of our communications. But I think the communications that really focuses on the science very much is caught up in that. And our credibility and our trust have worn very thin, or the public's trust in us, rather. So it's been making me think about some of the fundamentals of risk communication and how it applies to the demands of this long-term evolving situation. And one of the principles I've been thinking about is the principle of showing empathy, which, at the beginning of this, we were trying to really name the emotions that people were feeling. And I think that there was some resonance there in the way that we were blogging and the way our spokespeople were talking. Now I think the way of showing empathy relates much more to really trying to understand where people are, really having those touchstones in the community that can keep us grounded and community-centered into what people are experiencing now and what they've been through, and working that into our communications. And I think we've been most successful when we've been able to make the science information relevant using things like, scenarios. So the ways in which we can adapt that messaging to talk about and reflect what people are going through as parents, as workers, as people who live in multi-generational homes, as people who are facing barriers to things like vaccination. So when we can use those scenarios, I think people are more tuned in to what we're talking about. and to be judicious about when we explain the science, because people are feeling that fatigue. And we are hearing from our community partners and our community advocates that people are tired of having to weigh these risks themselves, that the kind of nuanced communication that asks them to make their own judgments is fatiguing for people, and that they want simple, direct recommendations. And so, how do we do that? How do we help them weigh that risk? And I think one of the things that we found is really leading with the very simple message that feels relevant, and then, using the science to back that up after we've given that simple recommendation. So for instance, one of our most popular pieces of content lately has been about masks, as the vaccine mandates have shifted, as we have lifted the mask mandates in our area, that having a blog that really listed from safest to least safe the masks, starting with N95s and going down to cloth masks, and so that people could see very simply which ones were the ones that we most recommended for safety. And then we give the science behind that. And by also including cloth masks, I think that helped. We explained why they aren't as safe, but here is what protection it does provide you, because that is people's reality. If they can't get it in N95, if they can't afford it, they are using cloth masks. And so if we don't include that, then we aren't staying relevant to what they're experiencing. I've also been thinking about consistency lately in slightly different ways, because, obviously as the data emerged, we could do our best to prepare people for the nature of changing data and let them know that things would be shifting. But I think consistency becomes more difficult when you have a lot of interests pulling at the messaging. And so, we may be, in addition to hearing about the science, and our health officer and researchers that we're connected to, being connected to that, there's also elected officials, policymakers, community advocates, and everybody is putting their own shape on that based on what their needs are. And it becomes, of course, most difficult when there's disagreement between these interests that leads to different policies. And that, of course, affects the communications. So I will talk about something that's not COVID here for a moment, and that's wildfire, which is, as everyone knows, a reality, especially out here in the West. And in Washington State, we have two different air quality indexes that are in place, because there's one that's the EPA standard used by our clean air agencies, and then there's another that's a state measure used by our State Department of Health and others within the state. And they have different thresholds for risk, and those different thresholds trigger different kinds of recommended actions. And there hasn't been agreement on the use of one of those indexes, and that makes things very challenging for communication, because the public is trying to figure out what they should be doing based on what they're seeing. They see it's smoky outside, and when we are talking about two different indexes, then people feel like we don't perhaps understand the science fully, and we lose credibility. And of course, it's very, very difficult when the policy doesn't follow the science or runs counter to what we've already messaged. And I want to just say that the past couple of days, I've been dealing with communications about the second boosters that have just been authorized. And we had spent so much time establishing with our public the processes that were in place as their safeguards. And that included expert review of the safety and the efficacy. And so now we're in a very difficult communication spot in which we can't address, like, why didn't that expert review happen in this case? And then I think that really gives us a hit to our credibility. So, it's a reality we're facing. So I think the ways in which policy decisions influence communications are one that I want to make sure I highlight here. And I'll stop there, because I know there's lots of other folks on this panel who have really wonderful things to say.
Oh, thank you so much, Meredith. So much in your comments there. We really appreciate that. Let's turn now to Uli Seal, the Fire Chief and Emergency Manager from the Bloomington, Minnesota Fire Department, for his comments. Uli?
Thank you. Yeah, my name is Yuli Seal. I'm the Fire Chief and Emergency Manager for the City of Bloomington, Minnesota. And our department is what we call a combination department. It's part career, part-time. And we share EMS response capabilities with both police, and our ALS provider is a private nonprofit ALS provider that provides transport in our community. And one of the things that early on we struggled with communications was specifically mixed messages. Mixed messages coming from different levels of government, both federal, then state, and somewhat less on a local level. And first responders, especially in the fire world, are rather direct and like clear direction. And there was some of that lacking initially. And there was a lot of fear initially as well with how to respond, and especially on the part of some of my law enforcement partners, because sometimes they were thrust into situations where they did not have the opportunity or the time to put PPE on. So winding our way through that and dealing with a disparity in CDC recommendations for PPE for first responders and what's realistic and what we can actually wear when we're, working a full arrest in somebody's living room in less than ideal conditions, and all those things kind of brought into play that created that communication difficulty for us. So one of the things that became apparent was in this messaging using unknown terms, and then having to not only explain unknown terms. A good example of that was and this was general to the public, but it was specific to my responders as well. Was an example would be that term "are not" when they were talking about transmissibility and the spreadability of the virus, and what does that mean, and what is an R naught of 3, and all those things came into play. And now you find yourself not only trying to explain the message, but also define some of the terms that are in the message, which created some problems as well, because quite honestly, there were many of us that were trying to explain these things to people where we were probably less than the right person to be defining public health terms to some of our employees. So using plain English, being very direct, and I think the other important piece, and you'll probably hear it more than once, is if somebody didn't know, they needed to say, "We don't know." And I know that this has been a very rapidly changing, in some cases, rapidly changing communications environment. And while I deal in the fire world and hazardous materials leaks and floods and all those things, and we find in those more readily recognizable physical dangers, that even with those, right, whether it's a severe weather outbreak, flooding, a hazardous materials leak, whether it's natural gas or whatever, that people tend to need to feel like they're in danger before they're willing to take action. And trying to convince people that there is a danger there becomes compounded when nobody can see it, nobody can really define it, and there's a struggle even amongst the experts on deciding exactly how you should proceed. So, making recommendations in these communications becomes important, that you give the message as to why that communication, or what that communication is actually based upon. And that, I think, would help prevent some of the early recommendations that got picked up and taken widespread, that created some of the hygiene theater we experienced, and some of those things that really weren't useful either in the response or communicating the real risk to our first responders. And I'm pretty close to my 5 minutes, so I'm going to pass the torch. Thank you.
Thank you so much for those comments. Let's go next to Amy Acton. Amy is the former director of the Ohio Department of Health. Amy?
Thank you. Hello, everyone. I'm honored to share my experiences. I want to couch it that I was at the beginning of the pandemic, so I'm going to talk about January through about June of 2020, because the things that I'm going to explain, I really think emphasize the fact that we have to have a bonding that occurs right out the gate. And to my colleagues who've been enduring what they've been doing all along, some of this won't apply. But I believe I was included because I was the subject of a New York Times op-ed in May of 2020 that was entitled "The Leader We All Wish We Had." And I'd love to tell you, they did a 60 press conference analysis, almost 7 weeks. And they came up with some core concepts that leaders need to own it, and that they should use brutal honesty, vulnerability, and empowerment. And I have to say, I'd love to say it was a linguistic style analysis from every pronoun I used. And I'd like to say that I was choosing it that selectively, but I want to tell you the backstory, how I stumbled into this formula. A couple things. First of all, big Josh Sharfstein fan. So I had learned, my C's of crisis communication in my training, but the CDC sends you for a special show orientation where you learn crisis communication for a weekend. Happened to stumble over my dog's gate, old dog that gets sick in the house, fractured my pelvis and missed the training. Ended up one of the many serendipities I'll explain, because I actually think in some ways I was the Ted Lasso of politics when I stumbled into this. And I ended up with not having that training in this moment, really going back to relying on, my kids would say it was just mom, what you saw, on TV, being a doctor, and how I try to communicate really hard truths to people. Secondly, I hired a brand new comms director 4 days before the pandemic started, and it turned out her brother had gone to my med school, just happened to be Rajiv Venkaya, who worked on George W. Bush's pandemic playbook. So I was able to have access to the people who did the plan right away. And in talking to him and Carter Mecker and some of their colleagues, as we all know, many of the scientists had gone underground, but by having that direct access, I learned so much so quickly. And they gave me a lot of the metaphors that I began to use, like layers of Swiss cheese of defense. Another serendipity is I was the Midwest representative to ASTO on the board, and ended up in the going to visit the Eisenhower building at the White House in the last week of February. It was unbelievable to see people who I've looked up at my whole career, and you could just feel the palpable tension in the air. We had been preparing for quite a while. We believed this was already here, but we were one of the states that had only one of the 3 reagents that worked. But in that meeting, we went around the room, and I was sitting next to a communications director for the president, and Mick Mulvaney was there, and everyone had said every science fact I could think of by the time they got to me. And it struck me in the face of this, as a person at home who was longing to hear more of the truth, who had Googled the word pandemic, even though I taught global public health and traveled for years, Googled it when the World Health Organization wasn't using the language I expected. And basically said to Mick Mulvaney, I really believe this is the higher angels moment. This is the FDR Winston Churchill moment, and people are just longing for a leader, to lead the whole world against a silent enemy. I got on a plane, I flew back. The governor and I met at an infectious disease unit. We met with the press for the first time, and again, all serendipity. We just said, and much to my governor's credit, Governor DeWine, we said to the media who had so many questions, we're going to tell you the truth, what we know as we know it. And we made that commitment. We instantly had to make a very hard decision about the Arnold Classic, a giant event that had 80 countries coming, 250,000 spectators. And we were making our first really hard policy decision. We decided to meet at 2 p.m. on the Ohio News Network. Who watches that, right? But we thought we could get everyone to press on time. And so we started this cadence, and then it was just so wonderful because the press were all there with us. In the end, they were going through things. Ultimately, we're sequestered, and just talking to one small camera. But in the beginning, the press were going through all the same things we were all going through. So we developed a relationship. We had the governor, the lieutenant governor, and me every day at 2:00. And as you know, we told the hard truths as we knew it. We were vulnerable. I was not scripted, which I think is probably one of the rarest things that has ever happened. But I would go with what was happening in the day and try to tailor it to people. And thirdly, we really consciously tried to empower the audience. We asked Ohioans, go help your neighbor down the street today, or watch the nurse's child who has to do the double shift. So we began this relationship. All sorts of words and phrases became contagious in our state. And people really, really, really bonded and moved together. I can talk more in the question and answers about how that unraveled. But I'd like to say something very important. We're going to talk a lot about communicating better, but people do need to understand that there were things going on behind the scenes that actively made that impossible. And for me, I can tell you, the day of the tweeting of Activate and Liberate, you could literally, certain things were changing. So I think it's really important always to look forward as we talk about how public health could communicate better. There was a very legitimate force that no amount of our great communicating could have overcome. So
all right, thank you so much for that, Amy, and we're looking forward to hearing more about that, about the breakdowns in the Q&A. I just want to move us along a little bit. Our next speaker is Jeanette Sutton. Jeanette is an associate professor at the College of Emergency Preparedness, Homeland Security, and Cybersecurity at the University at Albany SUNY. So, Jeanette.
Thank you so much. I'm really happy to be here and to participate. And I believe that I have a few slides that will hopefully pop up in just a moment. There's quite a few approaches about science communication and public health response. And I just want to mention just three. One, which is the crisis emergency risk communication model, which was mentioned yesterday as panelists talked about building and losing trust. That particular model focuses on the ideas of be right, be first, and be credible, and it provides evidence and advice to organizations and risk communicators on the most important steps to take across the time continuum from pre-event planning to post-event evaluation. And importantly, CERC takes into consideration the reputation of the organization as well as the strategies to build and maintain trust over the course of the crisis response. A second approach to science communication can be found in the research on health communication campaigns and messaging. And in this, health communication scholars take into consideration the importance of attitudes, beliefs, emotions, and self-efficacy, among other variables, as they work towards motivating longitudinal behavioral change. But the third approach, which I want to focus on in the remaining minutes of my talk, is found in social psychology, and its focus is on imminent threat events and behavioral responses to warnings. Research on disaster warnings has historical roots in the study of human behavior response in times of wartime. And in the 1950s, the Department of Defense funded research to study the psychological reactions and behavior of individuals and local populations in disaster. And it was for the purposes of developing methods for the prevention of panic and for minimizing emotional and psychological failures. But empirical evidence demonstrates that they were focused on things that were driven by assumptions and not on evidence. So that laid the foundation for ongoing investigations about how to communicate effectively under conditions that are urgent, certain, and severe, such as wildfires and other imminent threat events that have been discussed this morning already. So in the 1960s, scholars at the University of Colorado and at Oak Ridge National Lab developed a catalog of the factors that most affect behavioral outcomes in response to imminent threat messages. And I want to talk about those today. Can you put up the next slide, please? So this is what our warning model looks like. And we know, as Uli mentioned earlier, that it's very difficult to get people to believe that they're at risk and then to take action, because there is significant delays in taking protective actions when people don't believe they're at risk. And this is because people are social. And before we act, we confirm with other people, we look around for evidence of the threat that is approaching and figure out what we will do in response. So the model that you see on the screen on the left shows the relationship between perceptions that individuals encounter in response to warning messages. They first have to receive the message through all of the many possible channels that are now accessible, and then they have to be persuaded to act. Messages have to be perceived in multiple ways before that people will move to this behavioral response. They have to be understood. That means they have to be delivered in clear and consistent and certain ways. People have to believe that they are at risk and that the message is truthful. They have to personalize the information so that they'll be willing to take action. And then based upon the contents of those messages, they have to be able to decide to take the action. This is all taking place in something that we social sociologists call milling, which is really about confirming the message contents and the actions that should be taken at the same time that we're going through the other processes. On the right-hand side of the screen, you see that there are 5 different contents which we know need to be included in the message: the source, the threat and its consequences, the location and the populations at risk, and then the time that people have to take action and by the time that the message expires. And we've done this kind of research over many years, determining that these are the contents and also the message style in which messages need to be designed and delivered in order to reduce the time that people take before they take action. Can you move to the next slide, please? Thank you. So over the last several decades, we've applied this research in an all hazards approach. So you see on the left-hand side that we've identified not just the contents that need to be included, but also how to express those contents, and also the order in which contents should be delivered. In particular, when you're talking about short messaging channels, this is an image of what it would look like if you were delivering something over a wireless emergency alert, where we've identified that the first part of the message should include the source. The second part is the description of the threat or the event, telling people the direction that the threat is moving, explaining to people what exactly that threat can do to them and why they should take the actions that are recommended. And then providing those actions and telling people when to check for updates. My team is currently conducting research with funding from NSF, USGS, NOAA, and FEMA to study how to improve these messages across a range of hazards, and to develop software that will aid emergency managers and other risk communicators to compose imminent threat messages that will make a difference. The last slide, please. Because this leads to my last point, and I know I'm just about over time, Hillary. We don't know a whole lot about longitudinal risk communication. This is a key point that people have been bringing up. We don't know how to keep people engaged over a long period of time, how to motivate people to continue to take actions, how to help people to sift through massive troves of information, how to counter misinformation and disinformation, and how to manage human resources for the long haul. These are ongoing challenges. I think we're likely to be able to draw from research from risk communication scholars on the processes that sow doubt on topics such as cigarettes and smoking, oil and gas, and climate change, where there have been active disinformation campaigns funded by deep pockets. The addition of so-called social media as a communication channel certainly complicates things based upon that business model that promotes issues that increase emotional outrage at exactly the time when we need clear and reasoned and actionable information. So thank you very much, Hillary. I'm happy to turn it over to the next speaker.
Thank you so much for that. So many great points there. Now we're going to go to Inola Proctor, who is a professor at the George Brown School of Social Work at Washington University in St. Louis. Dr. Proctor.
Thank you. Well, my comments will be twofold. First of all, I want to emphasize the challenge of certainty and uncertainty for our communication And second, I'll identify some strategies from my field, dissemination and implementation strategy, that can help get evidence accepted and acted upon. But certainly this tension between certainty and uncertainty has proven with COVID, and I think through many public health issues, to be a threat to trust in science. But the reality is what we know today is different than what we knew yesterday. So this is an issue that I have to balance in my roles as professor and a professor teaching the public health workforce, and also a researcher and teaching researchers in the field of dissemination and implementation science. Next slide, please. So when I teach researchers, I ask them to focus on, first of all, to learn what we know, but then to zero in on gaps in knowledge. What we do not know and what we need to know is what I emphasize. But next slide, please. When I teach frontline providers, I know that uncertainty doesn't help them. I want them to know and appreciate that we have an evolving base of evidence, but they have to help people today based on confidence in the best available knowledge. So I have to help provide them with enough certainty for action. So how do we deal with the tentativeness of science? Well, first of all, I think we have to normalize the fact that knowledge is evolving and that that's a good thing, that new evidence is a good thing, and new discoveries should not really undermine the trustworthiness of science. Okay, next slide. And next slide. So now I want to emphasize 5 areas of dissemination and implementation strategies that can help with this challenge. And first of all, there are preparation strategies. We heard yesterday throughout the day the importance of being a part of the community. So we start early with forming relationships. We recognize that there are multiple audiences, and all of our messages have to be tailored to audience segmentation, specific messages for specific groups. And we have to, in preparation, pre-bunk misinformation. And there are a number of effective strategies for that. Next slide, please. And then we have to think carefully about the messengers. We heard yesterday emphasis on the role of community health workers and trusted institutions that have proven themselves trustworthy, champions of new information. And the concept of homophily I thought of yesterday about barbers in barbershops. These are messengers who are similar to the people they're communicating with, except for one important factor, and that is they have specific knowledge about the issue being communicated. So if we can train trusted champions and information messengers, they can work with groups with whom they have a lot of similarity. Next slide, please. And then we have to choose the message. And here, this is a challenge to synthesize. It's kind of like the Goldilocks issue, not too much, not too little. We also have to contextualize. I think drawing the similarities, making vivid that this builds on what we knew yesterday, but it is new. And again, within the theme of normalizing and contextualizing within the emergence of new data. Next slide. And then we have to be creative in using a variety of dissemination channels. There's a lot of research about the effectiveness of Black community newspapers. We've seen the effectiveness of radio stations, both in information and disinformation, and using people's social networks effectively. And the last slide, please. And then, of course, engaging. And our last comments from Jeanette emphasized engaging people over time. Oops, sorry, I set my timer. making sure that we vary the narrative, that we vary the channel, and that we use multiple channels of communication. So in summary, our challenge is, our blessing and our challenge is the evolving nature of evidence, and we need to equip ourselves with tested and effective strategies to get evidence accepted, acted upon, and that can actually change our behavior. I look forward to any further discussion or comments in the discussion.
Thank you so much. I'd now like to turn it over to Mitch Stripling, the director of the Pandemic Response Institute at Columbia University in New York. Mitch.
Hey, everybody. Thanks so much. And what a fascinating panel this is. I want to give 3 brief points from a practitioner perspective. Process points about this process of translation when you're in there fighting a fight during a public health emergency that I've seen, and things I would want to modify going forward if we can. So number one is that right now, I think that there is a divide between the scientists and the communicators. It's even there in this metaphor we use, translating, right? There's this idea that you generate the expert guidance and then you hand it to a risk comm specialist and they make it palatable to the community. And I think we need to make this idea of translation or building trust part of the guidance process itself. I've seen so many times debates, loud, vigorous debates between doctors and risk communication practitioners about a line in a guidance between the two expertise, and the doctors usually win in those discussions. And my take is that if it is guidance that goes out that is too complex for the public to understand, it's poor public health. It's not that it's a bad message, it's that it isn't good scientifically grounded public health guidance. So I would want to integrate this idea of storytelling, not just messaging, but storytelling into the guidance development process itself, so that it really ranks as high as public health expertise does, as epidemiology does as an expertise. That's what we see. Chief Seal's comments were important to me because that's what you kind of see in a classic ICS structure, right? Is that the PIO ranks right up there with the operational leaders. The second thing is that, to me, that story that we're telling then is more trustworthy if it leads to operational nimbleness, if it leads to the idea that we can change based on the context of the emerging incident. Too often in public health, we draw these red lines because we want metrics. And then by the time we hit that metric, whether that's a percentage metrics for mask wearing or percentage of vaccination, the context has changed around us. And we're kind of left holding the scientific bag that it seems like nonsensical at the time. I think that in an emergency, as Jeanette was saying, people suddenly do start to pay attention when they feel under threat, right? And because of that attention, we can afford to be more nimble. We can sort of turn the dial up and down based on the context. Now, we're afraid to do that because we don't want to confuse people. But my experience during COVID, I was running preparedness and response for Planned Parenthood all over the country. And it worked much better, just as Amy was saying, when you were brutally honest with people, when you were explaining the twists and turns, and when you were adjusting guidance to meet the needs of context. So if we can tell a better story, it makes us more operationally nimble, which I think builds trust, because people can tell when you're kind of BSing them about why a certain metric is scientifically grounded. And we fall into that trap, I think, too much in public health. Last thing is about community ambassadors. I think that Inola was really eloquent about this and about this idea of homophily. Within the public health structure, a lot of times we want to train community ambassadors or train community champions to reach a certain metric. And then we really want to hold them to that, right? The training sometimes is like, here's your script. Stick to this script that we're going to give you. And in fact, that often diminishes the power of speakers who are similar to their communities. In some ways, you want them to speak in ways that would not fly with you as public health institutions, because you want them both to speak to the language and the culture of their community. And so you really want them off script, right? You want to make sure that you're aligned in terms of values and mission. But beyond that, it's actually, in my experience, better if they're kind of calling you out to their community, right? If they can build trust in their community, even if the formal response mechanisms are taking a little bit of a beating in that process. Because the end goal is for them to increase vaccination rates or increase trust in the underlying science in that community. And that's what we care about. So I would say that if we entrust those community ambassadors to go out and do the work as they know it within the community, not try and kind of put guardrails around them, that helps us to stay operationally nimble, because we can also listen to what they're saying. And so that lets us kind of dial our operations up and down. And that's all based on the idea that this question of building trust, telling the story of the response is not separate or distinct from epidemiology or public health expertise that's core, but it's really the same piece. So I think those three sort of process changes would be really helpful in this question of translating public health into action. So thanks so much.
Well, thank you very much, Mitch, and thanks to all of our panelists for those really interesting thoughts. I heard some real similarities and differences amongst what you were talking about, really talking about the importance of empathy and being community focused, recognizing different audiences, telling stories, being authentic rather than sticking to scripts, you bonding with audiences and being vulnerable, and using language that speaks really intimately to people so that they can really latch on to what we're trying to tell them. At the same time, wanting to be really clear and direct and honest about what we know and what we don't know, and also engaging people over multiple channels in multiple different spaces. So really some really fascinating similarities and as well as differences in some of your comments. So I do have a few questions and answers, or questions that I'd like to offer opportunity to answer from the audience. And let's just start with the first one that I've received here, which is the research on using fear to motivate health behavior change is really mixed. But fear-focused messaging has been a staple of pandemic response. Was that a mistake? And I just open it up to the panelists to respond.
I'll jump in just to start that fear-based messages are successful when people are also given information that helps them to respond effectively. You have to balance out the efficacy information along with the fear, but fear should not be so strong that it stops people from being able to act, which is where our messaging really falls apart, is if it's just targeted at scaring people without giving them actionable information, then we have a significant problem.
Others?
I would just add that from behavioral economics, we're learning a lot about nudges. And I think we have to be careful that all of our messages about consequences, which is really, I think, what the fear messaging was intended, needs to be balanced with the option, as was just noted, of doing the right thing and making, I prefer to think of making the consequences of action clear rather than punitive.
I would also say the use of fear is in messaging to the point about balance is that if the consequences do not pan out or they don't realize those consequences, it diminishes the effectiveness, not only of the message, but the messenger. So telling people that, if you don't do this, you're going to die, and then they don't do it and they don't, it takes a lot of the credibility out of the message. So that balance becomes very important. And that's part of that risk, determining risk and selling that risk to people so that they do take action.
Thank you for that. Meredith, let me ask you, what were some of the conversations about how to balance, fear-based messages with other kinds of messages early on in the pandemic, and how have those evolved?
Yeah, I was actually thinking, what Fire Chief Seal was talking about. If the consequences don't pan out, then it loses credibility. And I think there is a difference that we have to understand in our world of population health, right? Where we understand that, and the death rates, the number of deaths in this country have been enormous. And at the same time, for individuals, it's not that same kind of consequence, because if they haven't personally experienced it, Fire Chief Seal's right that that it loses that credibility because they personally didn't die, or maybe they don't have people in their immediate networks that have died. And so I think it's a challenge as communicators to how do we convey, the population consequences, clearly. And that's the whole challenge of this risk calculation, because it may not happen to you personally, but it does have consequences. So thinking also, not just talking about death, but about spread, which does have real, that everybody that can have that impact. And then helping them think about, and what does that mean to other people who are more vulnerable, other people who are immunocompromised, or who are grandparents, maybe they're your child's grandparents. But I do think that it is hard to help people understand sort of the population level health consequences, because their immediate ones may be different.
Thank you. Here's another question from the audience. Amy mentioned that the whole communications atmosphere changed in Ohio due to conservative social media campaign. How would the panelists suggest that we react to those intimidation tactics and maintain public trust? Amy, do you want to kick us off there?
Yes. So let me say this first of all, just to circle back. Angela Merkel surrounded herself with a diverse group of people. She had theologians, historians, medical anthropologists. I think one of the great things they learned in that original pandemic playbook is they expected this kind of unrest, because they realized that there is a contagion worse than the virus in some ways, and that is fear. And it is the intolerance for ambiguity and all the other untetherings that have occurred and have consisted. And I would say to you that right now we are in another phase that we should be actually owning. It might be the most important phase of all, to weave this whole story back together, because it is a narrative. It is about relationship building, and we did need it from our leaders. And I want to tell you, all the hate and vitriol, again, the reason I'm making a point of the politics behind this is because I think if we don't do our 9/11 style commission and dig deep on this, we're not going to overlay a timeline of other incidents that occurred, and we'll think it's just the tweaking of the communication. I just want to say, I can't say enough. I think we'll miss what happened. The hate and vitriol was real. It was very targeted. We had, again, I had executive protection 24/7. I was the beginning of what would come to every school board, prison, every place in this country. So I want to say that. But the thing is, people need to know that that was a very small and very targeted group. There were some people that were ordinary protesters who were going through a hard time, the people you would go out and talk to. The people in my front yard, in my house, had rifles and automatics, and they were the same people that went to January 6th. So we cannot afford to not go back through the Bob Woodward tapes and back at things and see what was happening overlaying what we were doing, or we'll miss something very important. I want to say that it's about meaning making. So even right now, we have the opportunity to be helping people make sense of what they just went through, mourn the things they've gone through, memorialize it, learn the lessons. And again, this is a talent that is about relationships and hearts and souls as much as it is about the facts. Oh man, I'll just add one quick thing. The love and the going forward. I said 6 degrees of Kevin Bacon spread a virus. People made art. There's a Bacon statue somewhere. So we have got to use the arts and other things to help people make meaning of the impossible words we had to say, that in 2 weeks, your life would go from driving to work to looking like Wuhan. There aren't words enough in crisis communication to do that without metaphors and storytelling.
Well, any other comments from the panelists?
Yeah, I would just, I really, excuse me.
Let's go with Mitch.
Okay, sure. I want to build on what Amy's saying to both the question from Marcus and also the one from Monica a little bit. I do think that this kind of advocacy approach, this kind of broader storytelling, is something that public health is not equipped to do. I spent a lot of the COVID-19 early period running preparedness and response at Planned Parenthood. Now, Planned Parenthood, I think, is a great, important organization right now. You may have different feelings about it. But one important thing that we had within our ICS structure was an advocacy wing, which I had never experienced before in government. We had a wing of our incident command response that knew that anything we did would be political, would cause backlash, and was ready to sort of engage with that question. And to me, building a function like that is specifically charged with this question of countering, doing meaning making is really important. The thing that I would add to that is, to Monica's question, all of the work that we do about risk communication, public health preparedness capabilities, all that stuff can be undone in 5 seconds by a politician with a microphone across parties. And there are specific leadership competencies. Amy mentioned a couple of them for leaders of public health response, meaning making, sense making, and the like. So I think 2 additional things are really important. Number one, we do need a published set of competencies for top level politician leadership in public health emergencies, which I think various organizations have been kind of afraid to do for various reasons, right? It's a difficult thing for government to do. But also we need to understand that risk communication and this question of advocacy up the chain to those politicians are actually different skill sets, right? We need a risk communication storytelling arm and an arm that's ready to sort of advocate for leadership on an ongoing basis, and that they are kind of slightly different. We need to build both of those functions in our response structures.
Thank you. Inola, did you have a comment as well?
Yeah, it's really a question that builds on Amy's, I think, very poignant message that meaning making is going to be extremely important. And I think this is the time, because everything is fresh. And my comment is a question. What is the role of public health, and who is best equipped to construct the story of what we've been through? And can that be an important, public health providers and first responders? You have your hands full, but I really think Amy made a very important point. So who can do that?
I would add that there's some wonderful medical anthropologists out there, people who can take oral histories. We would love that. And just like Dr. Proctor said, we don't have time. Like we have talked on our team about, we wish we had captured the phases of the pandemic have been so different for us that we can scarcely remember what happened 2 weeks ago, let alone what happened a couple of years ago. And I think there is so much that we could do in constructing narrative now that will benefit not just the public health field, but the public at large. So I would welcome that.
Other comments on that?
I don't have all the answers to that, but I would just say, think about perhaps not being one person. I do think when we stumbled into it, before Delta came, Chuck Todd was waxing poetic about he almost missed the press conferences, but there was something about relationships and people with different strengths being consistent and talking together from different vantage points that I think was different and powerful, but the consistency. And it obviously would have been nice if it just, the more we can do it and stay across the board. Thank you.
I think if we had also had a national narrative all along from the beginning, that leadership at the national level, had set the narrative that the rest of us who are working on the ground could hook into about helping making sense, like national meaning makers. And of course, the politics play into all of this and made that terribly difficult to do in this situation. But, I think if we could have something that could be a narrative that could be used as a tool on the ground, and had people that they were dedicated to think about that in real time, that would be fantastic.
Thank you all for that. Speaking of tools, one question from the audience is: many local health departments are understaffed and underfunded and do not have equal access to communication tools. What resources and tools would you all recommend for health departments like these? And there are many across our country. Jeanette, do you want to maybe kick us off with some thoughts on that?
Sure. I'll just kick off and then pop it over to those who are practitioners who are actively doing this. The free tools are the social media tools, and also making connections with local media outlets who can represent your voice directly to your local publics. Social media is just really challenging. I think we're going to hear about that more this afternoon as we move into the other sessions, because there's just so much noise, and also getting your message to the top of the feed so that people actually see it is incredibly difficult, because the social media channels themselves produce particular algorithms that prioritize some information over others. And so there's real challenges in utilizing social media, and yet that's one of the simplest, most accessible tools for people who don't have the resources to put into more expensive strategies to get the word out.
I would also encourage local public health departments to, if they don't already have them, forge and maintain relationships with various universities that have health communication labs, health communication centers, and public health training, where there is training programs where there is some emphasis on messaging. I think, I speak only for myself and my university, but we're very engaged with our local public health providers, and I think most universities would welcome that.
Let me add two things. At the Pandemic Response Institute, our colleagues at the City University of New York are studying this question of communication, and they've done a lot of work with community ambassadors, boots on the ground, kind of as I was mentioning in my opening remarks. And our city health department has set up a public health corps, like an actual core of people, some of whom are paid staff, some of whom are volunteer, that are a new wing of the response. Hundreds of people who are out there doing kind of like community health worker work, but a little less trained, right? Because they're more informal. So what I would say to local health departments who are struggling with this is, hey, did you see how the Biden administration had a briefing with all the TikTok superstars about Ukraine, right? Are there ways that you can take the guidance you have and just empower people in the community informally with courage to go out and spread the message? We're worried about lawsuits sometimes, we're worried about some people saying things inappropriately. But if we have enough courage to go out there and to let people surge these abilities together and trust that makes it really powerful. I mean, I think the work that Carter Mecker and others did that Amy was talking about was kind of like that, right? They built this informal set of cultural relationships that weren't hierarchical. They were decentralized, and they let people pursue meaning making. And I think that was really important work that we need to make a formal part of public health responses going forward.
Thanks. Meredith, we've done a little bit of that at Public Health Salem County. Would you be willing to talk a little bit about those kinds of community relationships that we've let folks go out and make meaning with their own communities?
Yeah, we have a community navigators group that they are members of the communities largely that have been most disproportionately impacted by COVID. And we give them a stipend. That's really important to provide that kind of compensation. We meet with them every week. We talk about communications with them every week. They take what we give them and they do what they will with them. They give us feedback about what they want, so that we are, we had to hire people to do video, but they want a lot more video work. We've taught them how to use their iPhones to create their own videos. What we really are aiming to do is a lot of co-creation in which we can give them the background, but they can create the communications. I also wanted to just mention a few other tools that folks might find helpful. CommuniVax is an effort that's it's a collaborative between practitioners and researchers and put together a lot of great resources that talk particularly related to vaccine, but it applies to other things about how to work with community organizations and how to center them better in all kinds of work, including communications for public health. I think that the Fred Hutch, we just call it Fred Hutch, what's its formal name? For Fred Hutchinson Center for Cancer Research. They've got a lot of great resources as well. The Public Health Communications Collaboration, if you're not using that, that's the CDC Foundation and the de Beaumont Foundation, who kind of take a lot of these CDC messages and put them into a toolkit in ways that I think work better for people to answer questions. And then we found the Harvard polls that have happened actually to be really helpful to us, because we don't have time necessarily to collaborate with researchers in the moment. But when the Harvard poll comes out, we can do the audience segmentation that is core to our work, and that Hillary and I, when we have created campaigns, we can create personas based on that Harvard poll data so that we can really target our efforts, put our money behind the people that they've identified who are swayable. And so it helps us do much more targeted communications work. So there are resources out there. It is hard for us to work in time with researchers, but there are some really great resources out there that are a little bit more ready to go for us.
Thanks so much. Any other comments about tools or resources before we move on to the next question? Well, speaking of partnering with researchers at universities, local universities, one possible role useful role in the moment is evaluation. And so there was a question from the audience about what are metrics that should be or can be followed to assess the effectiveness of public health communications. How can we get better if we're not tracking outcomes? Any thoughts about that question?
I think there are a couple of metrics that we typically gloss over. Understandably, most metrics focus on the virus and its health consequences, such as positivity rates, hospitalization rates, mortality, morbidity. But that skips over some of the important processes that we're talking about in this session, such as having a finger on the pulse of community attitudes. Meredith said, she certainly doesn't have time to run polls, but I know some other countries have done a better job than the U.S. at monitoring social media messaging. So that immediately, South Africa had a whole initiative so that immediately, as soon as disinformation messaging was detected in their social media monitoring, they were able to track that and track the associated attitudinal and intentional responses of people about getting vaccinated. We lack data about the effectiveness of different implementation strategies. We may know how many vaccines were distributed at, say, an armory versus a school versus a subway stop, but we really don't have good metrics about what communication strategies were employed, for how long, by whom, with what community, so that we can have sensitive data about the effectiveness of various, we were all just trying to do something. And I think we glossed over the opportunity to collect metrics about the dissemination and implementation strategies and the associated changes in attitude and intention about mitigation and vaccines. So that just, I would argue that our public health surveillance needs to capture more processes and the intermediate responses of people, because traditionally we focus on more incident and burden measures.
Thank you very much, Inola. Yes, that is definitely a conversation of public health. We work in such a science-based organization, but the one area that we're not bringing a huge amount of science to bear is on our communication strategies and what's being effective and what's not. And any other thoughts on evaluation or how we can find out whether or not we're being effective?
One super simple point. I think we have a denominator problem in this area, right? Public health is all about numerators over denominators, right? Let's look at our population stuff. In communications, we tend to talk about eyeballs reached, uptake on Twitter. We chart those little spiky graphs of that. And that's not a good diagnostic because it doesn't include the underlying denominator of everybody you're not reaching. I think if we started just using denominators in all of our evaluation metrics for risk communication, we would suddenly sort of see how far we have to go and how much daylight there is there. And we would be less optimistic about our approaches as part of.
Right. Well, thank you for that. I think we are pretty much wrapping up. Are there any final comments that anyone would like to provide before we move on to the next session?
I can't say enough how much I hope and I'll continue to advocate for some sort of commission, both federally at a very deep level to settle all the nuanced part of this response. Some states, in my state, this won't be happening at the state level, most likely during this particular juncture, but is happening locally. But I think there's so much to discover. I think a new pandemic playbook with a whole different kind of lane for communications is the goal. Thank you.
All right. Well, thank you. All right. I think that is all the time that we have this morning for this amazing panel. I want to thank all of the panelists again for your remarks, and thanks to the public and others on the call who asked such great questions.